You can start now.
Bismillahirrahmanirrahim. It's my pleasure to start today talking about the stone disease in urology, and it seems to be one of the major topics in urology, since it is affect many group of patients in our community. I would like to thank Dr. Abdulaziz Amara. He's a consultant urology at Saudi German Hospital Group, and he will speak about stone management and approach. Since the stone is a well-known disease in our community, we face this in emergency room, in family physician consultation, and sometimes an inpatient consultation. Dr. Abdulaziz, the mic is for you, and welcome again. And we are so excited to hear from you.
Thank you, Dr. Muaz. Today, we give headlines about the line of management of the urolithiasis. Urolithiasis is a condition where the urinary stones are formed or located anywhere in urinary system, either in the kidney, ureter, urinary bladder, or urethra. The urolithiasis occurs in all parts of the world. In Asia, about 2 to 5%, and it's about 20% for key stage. It is due to hereditary factors, hot climates, and dietary factors. The peak instance of the age of urolithiasis from 35 to 45 years. Male to female ratio about 3 to 1. The recurrence rate about 50% within 10 years. We have different types of urinary tract stones, including calcium oxalate stone, urate stone, strophyte stone, and cystine stone. About 75% of the urinary tract stones are calcium oxalate stones, which grossly appears hard and spiky. And X-ray, it is a radio-opaque stone. The house-filled unit about 1,700 to 2,500 house-filled units. These calcium oxalate stones usually due to metabolic hypercalcemia and hypercalciuria. 10 to 15% of the urinary tract stones is a uric acid stones, which grossly appears as smooth and friable. It is easily fragmented, and in the X-ray appears radiolucent stone, the house-filled unit 200 to 400 house-filled unit. Usually it is due to the hyperuricemia and the hyperuricemia. Infection stones or strophyte stones, it is represent about 5 to 10% of the urinary tract stones. This appears lamellated. It is radio-opaque stones due to recurrent or persistent renal infection. About 1 to 3% of urinary tract stones is cystine stones, which hard, mild radio-opaque stone caused by cystinuria from hyperuric acid urine. Grossly, the stones appears as surface, then shell, and the stone material, and in the middle there is nevus. The urinary stones formed is a result of complex process involving metabolic factors, anatomical factors, presence of infection. Patient with urinary tract stones usually presented by renal colic, hematuria, storage lower urinary tract symptoms, and sometimes asymptomatic if it is Stackhorn stones not mobilized with no hydronephrosis. The investigation of the patient with urinary tract stones by X-ray, ultrasound, non-contrast CT, and IV. The X-ray appears radio-opaque shadow, as we see, radio-opaque shadow in the region of the right kidney, or radio-opaque shadow in the region of the left kidney. Here, there is a radio-opaque shadow in the course of the upper right ureter, and there is multiple radio-opaque shadow in the region of the urinary bladder. This is IVU, especially in the radiolucent stones. It appears as filling defect in the pelvis of the right kidney with hydronephrosis. The ultrasound has a role for the diagnosis of the urinary tract stones, including as acoustic shadow in the region of the kidney, or there is obstruction in the ureter, which appears as mild hydronephrosis in the right kidney. There is also acoustic shadow in the urinary bladder, which represent the vesical calculi. CT scan is a gold standard line of diagnosis of the urinary tract stones, either radio-opaque, radiolucent, or any type of the stones. Here there is stone right kidney. About the prophylaxis for the stone formation is, in spite of the long decades of the investigation and the clinical trials, the patient asking for prophylaxis for those stones usually meet one answer: please drink water a lot. Also, reduction of spicy foods, soda, and meat, proper treatment of recurrent or persistent urinary tract infection, which one of the cause of the stones, because as we know, the triad infection, obstruction, and stone formation. Early and proper management of any urinary tract anomalies like pelvic junction obstruction, refluxing ureter, stricture ureter, posterior vesical valve, and other congenital anomalies, which is usually may be associated with urinary tract stones. For the patient with recurrent and pediatric stones, metabolic workup and regular re-evaluation for this patient is very important, as 24 hours calcium, 24-hour phosphorus, serum calcium, serum phosphorus, parathyroid hormones, etc. Regular follow-up schedules for the patient post-removal of stones for prophylaxis against the stone recurrence. As we said, about 50% of the case underwent the recurrence of the stones in the first 10 years after removal of the stone. We have main lines of treatment of the stones, but it depends on the patient factors, stone factors, urinary tract factors, but we choose according to all of these factors, like age of the patient, sex of the patient, weight of the patient, also the even job of the patient, also about the site of the stone, the size of the stone, the density of the stone, also if there is obstruction, distal obstruction, associated infection, all of these factors we can choose the line of treatment of the stones. We have medical treatment, ureteroscopy, BCNL, also ESWL, open surgery. All of this is depend on many factors, not only the X-ray, but also the patient itself. The most common line of treatment of the urinary tract stones, especially the urethral stones and the renal stones, is the ureteroscopy. Ureteroscopic manipulation of the stone is commonly applied method for the stone removal. Flexible ureteroscopy allowing the tapping of even lower calcial stones. The stones are removed usually by the stone basket. This is a picture of the flexible ureteroscopy, and this is the kidney, ureter, and the bladder, and this flexible ureteroscopy passing through the ureteric orifice and then to the ureter, reaching the site of the stone in where upper ureter of the kidney, and underwent the laser fragmentation, and then after that removal of this stone by Dormia basket. There are different methods for fragmentation of the stone, either mechanical, ultrasound, pneumatic, or laser. The most common type of laser is a holmium YAG laser. This occurs through the mechanism which is caused by the stone vaporization, highly absorbed by the water. This is most common type of the fragmentation of the stone is a laser fragmentation of the stone. After fragmentation of the stone, we remove these fragments by Dormia basket as we see. This is a video showing, demonstrating the ureteroscopy.
Ureteroscopy is used to remove kidney or ureteric stones and enables a direct view of the ureter and kidney to confirm or rule out other abnormalities. This animation shows the removal of a kidney stone. Ureteroscopy is typically performed with the patient under general anesthesia. A small tube is passed through the urethra into the bladder, and from there up into the ureter and into the kidney. A contrast study may be performed to assess the anatomy of the renal collecting system before stone removal. A contrast agent, or dye, is administered through the tube into the ureters. X-ray images clearly outline the urinary channel and exact position of the stone. A so-called safety wire that helps guide the ureteroscope through the ureter is inserted. Depending on the location of the stone, a rigid or flexible ureteroscope is passed through the urethra into the bladder, following the safety wire into the ureter, the small tube that drains urine from the kidney to the bladder. Once the stone is located, it may be pulled out directly with a so-called stone basket, or a laser is used to break the stone into smaller pieces before extraction using the basket. After stone extraction, the collecting system is checked to ensure that no residual stones have been missed. Your doctor may place a temporary small tube, called a stent, within the ureter at the end of the procedure to ensure that swelling does not block the drainage of the urine. A catheter, which is a tube placed through the urethra into the bladder, may be used to drain the bladder. This catheter remains in place with the use of an inflated balloon. The catheter and stent are usually removed shortly after the procedure. You can leave the hospital once you are able to empty your bladder sufficiently and you have no fever or pain.
This is a technique of simple ureteroscopy, flexible ureteroscopy with laser fragmentation, just demonstration, The second line of treatment is a PCNL, which is a gold standard line of treatment of the renal stones. This is a short
Your doctor has recommended that you undergo a stone removal procedure called Percutaneous nephrolithotomy, or simply PCNL. The goal of this procedure is to remove all your kidney stones and, when present, ureteral stones. This animation shows the removal of stones in the kidney. PCNL is carried out under general anesthesia. When you are fully sedated, a catheter, which is a hollow tube, is placed in the bladder. The bladder catheter drains the bladder and remains in place with the use of an inflated balloon. Another catheter is placed up into the ureter. Through this catheter, a contrast, dye, may be instilled to allow a better view and exact stone location, and to facilitate access to the kidney, while your urinary tract is visualized using X-rays or ultrasound. Once the stone is located, access to the collecting system of your kidney is gained using a thin needle. This access route is carefully dilated. The guide wire allows the nephroscope to safely access the kidney. Some stones can be removed directly using a grasper. Larger stones need to be fragmented first, using a device like a laser before extraction. After removal of all the stones, your surgeon will perform a contrast study. When there is good passage of contrast material to the bladder, this means that the ureter is also stone-free. In some patients, a temporary small tube, called a double J stent, may be placed to ensure that swelling does not block the drainage of the urine. The stent remains in place by J-shaped curls in both the kidney and bladder. At the end of the procedure, a nephrostomy may be placed. This catheter helps to drain your urine. The catheters and stent are usually removed shortly after the procedure.
Also, we have ESWL, which is a common line of treatment of the stone, especially renal stones, upper ureteric stones, also bladder stone. And this is used for the stone pelvis, upper calyx, upper ureter, and also in the pediatric. You see?
Your doctor has recommended that you undergo a shock-wave lithotripsy. During this procedure, external shock waves are directed to the location of the stones in your body and which break the stones into tiny pieces. When you urinate, these pieces are then discharged from the body along with the urine. This animation shows the removal of stones in the kidney. There is usually no need for general anesthesia, but pain medication is administered for comfort during the procedure. You are placed on an operating table with your flank positioned towards the shock wave generator. Imaging with X-rays or ultrasound might be performed to pinpoint the exact location of the stones. Focused shock waves are then transmitted to the stone through the skin. The stone absorbs the energy of the shock waves and breaks into pieces as small as grains of sand. Because of their small size, these pieces can pass easily from the body along with the urine when you go to the toilet after the procedure. The procedure lasts about 45 minutes. If you have a large stone, it is quite common that you need multiple sessions to completely break it. Your doctor will inform you on the needed course of treatment. After the procedure, your doctor will see you for a follow-up to check if the stone completely broke up and got flushed out with the urine. You will be given a urine strainer to catch the bits of stone passed in your urine for further examination. Sometimes a stone fragment can temporarily get stuck in the ureter on its way down. This can cause some blood in your urine, congestion, and even pain. If you are in pain, use the prescribed painkillers and temporarily drink only small amounts to minimize the congestion. Contact your doctor if you develop fever. When the pain is under control, you can start drinking normally again.
As we see, the ESWL is one of the line of treatment of the urinary tract stones without anesthesia, without pain, short recovery, short hospital stay, rapid recovery, and this is important for the small stones. Also, open surgery, it exists for the difficult and complicated cases. So the rule of the good urologist start by good choose of the case of the few variable consideration. Number one, patient consideration: age of the patient, general condition of the patient, socioeconomic standard of the patient. Also, the stone consideration, like size of the stone, shape of the stone, also density of the stone in the X-ray. Consideration on the urinary tract, like anatomy, infection, associated pathology. Also, you have to consider ourselves about our talents, experience, equipments, and training. So the decision making about the stone procedure, how to manage this stone, is depend on all of these factors. Take-home message: stay well hydrated is a key step for prevention of the renal stones. Consider the urinary tract, patient stone. Consider your patient and yourself during the decision making for the stone treatment. Share your patient in the choice of the best method for the stone management. Keep in contact with your patient after stone management for re-evaluation and prophylaxis of the stone recurrence. Thank you.
Thank you, Dr. Abdulaziz, for a nice presentation, which cover many things in the stones. And I will open the session for the question, if there is a question. There's one question, Dr. Abdulaziz. They mentioned in case of renal colic with obstructed stones, are you going to give IV fluid with analgesia or only analgesia?
If there is obstruction, it's better to give analgesia first, because if we give IV fluids, maybe increase the retained kidney and upper ureter with fluid, and this may be increasing the pain.
Okay, one of the question here, they mentioned which type of analgesia you are going to give in case of renal colic.
We start by non-steroid anti-inflammatory first, but the narcotics like Percutaneous, it is also indicated in the case of the severe pain.
Okay.
There is one question also, Dr. Muaz, about the
Yes.
role of the alpha blocker like Omnic in the lower urinary tract small stones.
You know, many studies, they mentioned that the efficacy of alpha blocker for urinary tract stones, whether it's upper or lower or mid-ureter. And we believe that this medication will improve the stone passage, as well it will decrease the pain. Many studies, they show that using alpha blocker will decrease the consumption of analgesia. I think it's a good idea to give the patient alpha blocker, but you have to mention some side effect, which is very, very, very important and common, especially when you use non-selective alpha blocker like orthostatic hypotension, and which is temporary, usually for 48 hours or 3 days. This is very, very important. I think it's a good idea, a combination alpha blocker with non-steroidal anti-inflammatory medication. Usually, I give the patient for renal colic, if they are the acute setting, I will give him non-steroidal anti-inflammatory medication. You have to check the contraindication like asthma or patient with severe renal impairment. I would like to mention also for the non-steroidal medication, it will decrease the GFR. And if you decrease the GFR, it will decrease also the urine output, which will decrease the pain, which is another way to relieve the pain from the renal colic. As we know, the renal colic, it came from not from the stone itself, it came from the back pressure to the renal pelvis. If you decrease the preload for the fluid, it will improve the pain, and you will manage it in a very nice way. For the renal colic, the most important, you have to explain to your patient that you should give him a maximum treatment of analgesia. Otherwise, the patient, he will come to the emergency many times in the week just to take morphine, for example, because he don't know how to take this medication in a proper way. For example, for the renal colic, you have to tell your patient that you have to take it. If he have sudden renal colic, you have to take it for at least 48 hours with continuous analgesia. Then if he feel a little pain, he should take it. He should not wait till the pain starts to be severe, because if the pain starts to be severe, in this case, the patient will have nausea and vomiting, and sometimes he cannot tolerate the medication. And the same way for the non-steroidal medication, it's better to give the patient a proton pump inhibitor to decrease the risk of gastritis. Since these patients usually they don't eat enough and they may have empty stomach.
Yes, thank you, Dr. Anas. There is also another questions about the side effects of the ESWL.
I think this is your question, Dr. Abdelaziz. It's for you, I think.
About the most important side effects of the ESWL is a distal obstruction. So we choose the size of the stone to prevent this. If we have too much big stone, we have to bypass, put a stent like a stone in the kidney, and have more than 2 centimeters stone in the pelvis. And we choose, the patient to choose, I want the ESWL. So we have to fix the double G stent to prevent if this one part of the stone is broken and then causing obstruction on the ureter. This may be causing obstruction, causing pain, causing hydronephrosis, and maybe infection, maybe fever. And this you have to bypass the ureter. Also about the stone fragments, maybe this causing obstruction in the ureter, like Steinerstrass, which obstructing the distal part of the ureter because of the fragmentation, even it is 1 centimeter or 2 centimeter stone. So we have to counsel the patients about this. There is some accepted drawbacks like hematuria, like pain due to the edema, due to moving of these particles of the stone through the ureter to pass. But if there is a persistent pain, persistent vomiting, hematuria, or fever, the patient should be follow the doctors and to be relieved doing CT scan without contrast and relieve this obstruction by double G stenting or ESWL. So the complication of ESWL may be managed also by ESWL.
I think ESWL is one of the very nice minimally invasive option for stone treatment, but we have to choose a good patient and good type of stones. Stones which huge stones or stones in the mid-ureter to be difficult to treat it. We have to explain to the patient that he may develop renal colic after ESWL, and he may need also double G stent if he don't have double G stent before. Pediatric and shockwave, it's very nice. Why? Because the pediatric, they have a good ability to remove the stone, or good ability to pass the stone, because the ureter will be nicely dilated and the pain will be less. Yes. One of the question here seems to be a long question. It's a lady. She mentioned that one of her son, he have one side hydronephrosis since antenatal screening, and even at 9 months he still have hydronephrosis. The question: does he need follow-up? The second question: is it something to worry about it? The third question: is it going to resolve by itself or we have to do something for this hydronephrosis? What do you think, Dr. Abdulaziz?
This is antenatal. I don't know if it was, because I not see the.
Yeah, this is they mentioned that it was antenatal and postnatal. At 9 months, still there is a persistent hydronephrosis.
Yes. We not hurry about this case. We have to follow the hydronephrosis by the ultrasound in the first months, and then in the second months after delivery. But if there is persistent, we have to deal with this obstruction.
Okay, I think it's a good question, because usually they are worried about their babies, and is it going to affect the renal function later on or not? That's why I think it's good to see pediatric urology, and they may ask for other nuclear scan in order to evaluate the renal function and to be sure that is it affected or not. But obstruction should be always, we see it in the urology, obstruction should be resolved.
Also, another question, Dr. Muaz, about the pain management lines.
I think we mentioned that before. It depends on the patient situation. If the patient, for example, he can't relate orally, we can start by giving them, and there's no contraindication for non-steroidal medication, like patient who has history of allergy to non-steroidal medication, patient who have severe renal impairment. Even some study, they mentioned that if you give non-steroidal medication for mild renal impairment, it will not affect the renal function. We will start by non-steroidal medication. If the pain is severe enough and it is not resolved by the non-steroidal medication, we can give the patient morphine or morphine derivative, and usually it's helpful. If, for example, the patient is not responding to this classical analgesia, at that time drainage will be the second option. What I mean by drainage, whether to put the double G stent, which means a tube by the natural way, or a nephrostomy tube if the patient is not stable, to go to OR and doing double G insertion by endoscopic rule. What I would like to mention in this case, that unfortunately our patients, they are not taking the medication in a proper way. That's why they have recurrent pain. If you explain to your patient how to use the medication and when to use it, they will relieve the pain, and they will reduce the risk of ER passage.
Thank you, Dr. There is a question: if the stone is silent without obstruction or pain, did you interfere or not?
Okay, this is a very good question. If the stone in the kidney and it's less than 5 millimeter and it is not symptomatic, which means there's no pain, there's no recurrent infection, there is no hematuria, in this case, I will follow these stones, usually every 6 months or 1 year with ultrasound. What is very important in this case, I would like to know the household of the stone. If the stone is uric acid or it is an oxalate stone. If it's uric acid, we can dissolve the stone by giving the patient alkalinization, which is with the potassium citrate or sodium bicarb. By this way, the stone, it will dissolve if we did a good alkalinization. If the stone is symptomatic, which means the patient have chronic pain, or there is a risk of, or there is infection related hematuria, patient who is going to travel in an area where there is no medical facilities. He will go, for example, in Central Africa, and if he have a renal colic there, it will be a problem. Even if the stone is not symptomatic, I would do it. If the patient, for example, is a pilot, okay, and he have small stone still in the kidney, but unfortunately, if he get a renal colic while he's in his work, it will be difficult situation. Another social reason, for example, if you have a mother with 3 or 4 kids and she should take care of them, and she afraid that he may develop renal colic at any time, and she cannot arrange for her kids. At that time, I will treat it as elective cases for this social reason. But a general rule, 5 millimeter less or less asymptomatic, we can survey.
Okay, thank you very much. Here are also medications, which is best medications of the stones. I think it's depend on the type of the stone. It's urate stone or calcium oxalate stone or cystine stone. Is this stone is obstruction, also the size of the stone, also the situation of the stone. If there is calcium oxalate stone, we choose the acidification of the urine. If there is uric acid stone, we do alkalinization of the urine. If it is a small and distal stone, we use also the, as we said, alpha blocker, tamsulosin. It is help the dilatation of the ureter and help for expulsion of the stone. Also, a lot of the fluid intake. It is very important for helping the expulsion of the stone. So we use something to push the stone by the fluid, and something to dilate of the stones, which is alpha the ureter. As alpha blocker help the expulsion, and the alkalization or acidification of the stone according to the type of the stone, helping the decrease of the size of the stone, which to be facilitate the spontaneous expulsion of the stone. But we have to follow this patient close observation to detect the degree of obstruction. Because some patients have high pain threshold, and this patient not feeling pain like other patient, and this maybe there is obstruction, and this causing severe hydronephrosis, and maybe this kidney is lost, and the patient is go home and maybe come back after 1 to 3 months with the stone, still the stone is present with severe hydronephrosis and maybe lost the kidney. So we have to instruct our patients, if we give medical treatment, keep in close observation with us, close contact with us to follow up of this patient, not only about the pain, but also about the radiological evaluation of these patients, about the degree of obstruction and hydronephrosis, presence of the infection, development of the ureteroscopy.
This is a very nice point, Dr. Abdulaziz, because the kidney can preserve the renal function if there is total obstruction for 45 days. After that, they may have a permanent damage of the kidney. If the patient, for example, have renal colic and the stone is obstructed, we can wait from 4 to 6 weeks. After that, there will be a permanent damage of the kidney, should be drained. The patient should have a definitive treatment for a stone. There's one interesting question, and we face it all the time in urology clinic. The patient, they want the answer in Arabic. What about منقوع البقدونس? This question, what do you think, Dr. Abdulaziz? بس هي تبغى نجاوب بالعربي لأنه تبغى تعرف الجواب بالعربي.
وطبعا البقدونس من الحاجات الجميله اللي احنا بنحبها جدا في الستون مانجمنت او في الحصوات الصغيره، وده نوع من اللي هو بيعمل ادرار للبول، وفي نفس الوقت يعني كماسل ريلاكس او بيعمل توسيع للحالب عشان يساعد على ان الحصوه تخرج. فده من الحاجات اللي احنا بنحبها وبنريكومند الحاجه دي وبننصح المرضى والزوار بتوعنا بيها. بس هي مش هي اللي هتبقى الحاجه الوحيده اللي هي بتساعد على ان الحصوه تخرج، ولكن احنا بنبقى بنساعد، بنقول والله احنا ناخد علاج، بنقول خلاص احنا قلنا احنا اخترنا ان احنا ناخد علاج، خلاص ما قلناش ان احنا هناخد حاجه ثانيه او هنستخدم وسيله ثانيه، لا منظار ولا تفتيت ولا اي شيء. احنا هنقول خلاص الحصوه دي صغيره وموجوده في الحالب، مش عامله انسداد شديد، الالم مقبول، امور كويسه، يبقى احنا هنختار مع بعض مع المريض بتاعنا بعد ما نتكلم معاه ونشرح له حجم الحصوه ومكانها وتاثيرها على الجهاز البولي، فبنقول له والله طيب احنا هنبدا ناخد العلاج. العلاج ده هيبقى زي ما اتفقنا، هناخد مسكن عند اللزوم، هناخد حاجه توسع الحالب، هناخد شيء برضه فوار كده عشان يساعد ان الحصوه تتقشر كده من فوق لغايه ما حجمها يصغر عشان تساعد ان هي تخرج. وكمان هنقول له بقى، ننصحه نقول له بعد اذنك ممكن ناخد سوائل كتير. من ضمن السوائل اللي احنا بياخدها المريض ان احنا نقول له مثلا البقدونس ده كويس، بيساعد ان شاء الله معانا، بيريح الالام، مضاد للتقلصات، بيوسع الحالب، متر للبول، كل الحاجات دي كلها يعني احنا بنستخدمها، بس هو بيبقى كومبلمنتري او حاجه بتساعد العلاج بتاعنا ان هو يبقى تاثيره كويس.
هذا جواب ذكي، هذا جواب ذكي يا دكتور عبد العزيز، لانه الدكتور عبد العزيز اضاف انه هذا البقدونس هو اضافه الى الادويه وليس هو الدواء. زين، لما ترجع للابحاث تلقى ما في كلام واضح، ناس يقول مع وناس يقولون ضد. في من ناحيه التركيبه ايضا كل شيء ذكر دكتور عبد العزيز انه يساعد على توسيع الحالب، وانه احيانا في انت يعني مضاد للالتهاب ومضاد للبكتيريا ومدر بنفس الوقت. لكن لما ترجع تشوف بالضبط كم يعني هل انقعه، هل نغليه، هل نستخلصه، ما في ايضا شيء واضح. كل الستاديز الموجوده قليله جدا في هالموضوع، او اغلبها ستاديز موجوده اللي هو ناس يتكلمون عن التركيب. فانا اقول هذا سؤال ذكي او جواب ذكي من الدكتور عبد العزيز، انه يقول هو مجموع يعني ممكن نحطه من ضمن الكوكتيل، بس قد لا يكون هو الشيء الوحيد اللي ممكن يعالج. زين، ابغى انبه الى شيء معين، انه مدر، فبالتالي الناس اللي عندهم قصور في الكلى يشربون طوال الوقت المدرات بدون ما يكون عندهم تعويض عشان كميه السوائل اللي فقدها، هذا ممكن يضر على وظائف الكلى، خصوصا الناس اللي عندهم قصور في وظائف الكلى او الناس اللي عندهم زراعه الكلى. فمثل هذه الادويه او الاعشاب او كذا لابد يكون الانسان عنده انتباه في القصه هذه، وانه ما يستخدم منقوع اشياء كثيره مخلوطه مع بعض ما نعرف وش تاثيرها الطبيعي. وهذا الكلام ايضا يقال مثل على الصمغ العربي وخلافه. ما نمنع منها، لكن في نفس الوقت نقول بوضوح انه ليس كل شيء، اقصد انه لا يوجد دليل ما يعني ثابت انه فعلا تؤثر، لكنها لا تضر، لكنها لا تستخدم لوحدها. وزي ما قال دكتور عبد العزيز لابد من المتابعه. ترك الحصوه في مكانها لفتره طويله معناها انه ممكن ياثر على وظائف الكلى على المدى البعيد.
شكرا جدا يا دكتور معاذ. في سؤال جميل برضه يعني نستفيد بخبره الدكتور معاذ في الليزر fragmentation of the stone. What are your laser parameters in the ureteral and renal stones in setting of flexible ureteroscopy?
It depends what you are going to do. Are you going to do fragmentation only to fragment the stone, or you are going to do whether fragmentation in a big sizes, or you're going to do crushing. You are going to crush the stone. You don't need to just to have it as small stones of 3 millimeter. If you have if you want to just to do fragmentation, I will increase the joule, and I will decrease the frequency. If I am going to do a dusting, which means the stone will be like a sand, by this way I will decrease the joule and I will increase the frequency. The other question related to ureter. As we know, the ureter seems to be difficult sometimes situation because you are not far away from the mucosa, and you may injure it and you may do perforation. Not only that, if you are going to use the fragment dusting, unfortunately, by increasing the frequency, some of the fragment will be immigrating to the kidney back. By this way, you will have a difficult situation because you have to go there and you have to recover you have to take your stone. The answer is depend what you are going to do. Whether it is just only to fragment the stone in 3 or 4 pieces, then you will take it, or I am going to do dusting, or is the stone really in the ureter, and I don't like to lose it in the kidney. Because if I use, for example, a rigid ureteroscope and I don't have a flexible ureteroscope, by this way I don't like this fragment will be migrate back to the stone because I don't have any access to take it back. By this way, I like to have fragmentation by using high joule, and I would decrease a little bit the frequency.
Thank you. Very nice. Very nice. Very nice.
Thank you so much, Dr. Muaz. Thank you a lot, Dr. Abdelaziz, for the interesting presentation. Thank you, everyone, for joining us for today's webinar. The certificates will be sent by email after 3 days. Next webinar will be coming Saturday at the same time. The topic will be recent advances in management of acute ischemic stroke. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh.